So for just our little outline here, we'll just talk about the background of minimal change and then talk about treatment options, kind of reflecting on like historical treatment options and then newer agents. Okay, so just as like a clarification, so remember that when we talk about minimal change, when we think about our nephrotic syndromes, really what these are podocytopathies, right? Like they are damage to the podocyte that's leading to massive losses of protein, hypoalbuminemia, and we distinguish podocytopathies based off what we see on histologic exam, right? And so of those, we have membranous, which is fairly well defined at this point. We know what it looks like. We have an antibody for it. But minimal change in FSGS are not as well defined. Certainly they have different pathologic appearances, but I just, for the boards, minimal change in FSGS are separate entities, but I want you guys to know that more and more these days, they're seen as the same process essentially, or just different manifestations within like a similar disease spectrum. So to like kind of sum that up, people kind of see them as the same disease, just at different points on the spectrum. And that's sort of how they're being viewed. And when you read papers about them, they're more and more referred to as idiopathic nephrotic syndrome or podocytopathy, and they're kind of one and the same to some degree. But for the purpose of this talk, minimal change is going to be pretty much minimal change as you know it. So obviously, minimal change is a nephrotic syndrome secondary to diffuse podocyte effacement with minimal additional histologic findings. It was first described in the 1920s as lipoid nephrosis. And when we developed EM in the 1950s, the ultrastructural analysis basically was able to define minimal change where you saw that podocyte effacement on EM, but nothing else really. So it's the most common cause of nephrotic syndrome in children, it's 80% of them, and it's the third most common in adults, 18 to 20% of adults. It's more common in South Asians and Native Americans, and it tends to be more in males in adults, whereas in children it's more equally distributed between genders. Obviously, we have primary minimal change that we know about, but you can have secondary minimal change due to like allergens, malignancies. There's a big association with lymphoma, thymomas, medications like NSAIDs, interferon alpha, and then infections like certain viruses. Okay, so clinically, we kind of know how these people present. They show up all of a sudden acute onset edema and sarca. They can be normotensive, especially in children or in the classic presentation. They can have hyperlipidemia, hypoalbuminemia, intact renal function, nephrotic range proteinuria. Adults tend to have a little bit more hypertension, hyperlipidemia. They have a higher risk of AKI. 33% of them will often have AKIs. And there was apparently somebody biopsied some of these patients, and the AKI was seen predominantly due to tubular injury, like 64% of the time. But, there's also a good amount of arteriosclerosis in these patients because they're adults, interstitial inflammation. So there's higher likelihood of AKI in men, older patients, that kind of thing. And so complications, obviously, of nephrotic syndrome, when you're losing all of your immunoglobulins, you have a high risk for infections, you're at risk for clots, thromboembolic events, and then AKI. So pathologically, typically what we see on light microscopy is not much, maybe a little bit of mesangial cells, but really nothing specific. IF, I don't have a picture of IF up here, but generally it's nothing, although maybe there's some kind of, kind of like C3 IgG that's on there if that really has much to do, but they've kind of noticed that. But the big finding is the diffuse podocyte effacement on EM, which obviously you can see here. These are not normal podocytes. They're all sort of flattened and sad looking. Okay, so why do we, oh nice. I'll pause for sandwiches. Thanks, you guys.
I don't know what no CF means, so good luck.
And there's.
PETA that they didn't put in each one, but should go with each one.
Thank you. Thank you. Don't forget to grab stuff to show you guys. Normal.
This is state.
Sure, thank you. Yeah, the bag.
Yep.
Thanks, sir.
Yeah.
Oh my God. Everything's so fast.
Best in the world. Right.
Yeah, she and what's her name, another patient. Sorry. No, it's okay. But she and the other young little patient both think the same, seemed to question mark toxic medical. Like, oh my God. There's a really good epidemic.
Question about what causes minimal change, and similarly with FSGS, we're not entirely sure. There hasn't been like a soluble factor that's been truly elucidated yet, but minimal change historically was thought to be a T-cell mediated disorder. One, because you don't have immune complexes present. You don't see electron dense deposits anywhere, so less likely B-cell. There's also the association with lymphoma. So from like the 1970s onwards, it's kind of thought to be T cells, but the upregulation of CD80, activation of T cells didn't really hold up across patients. So then they thought, well, maybe it's a cytokine or it's something else that's being released by the T cells. And then basically this led to a lot of questions of like, well, maybe it's a local factor. Maybe it's something actually at the podocyte that's leading to changes to the anionic sites on the glomerular basement membrane, podocyte effacement. We know that nephrin is like heavily involved in the slip membrane, so something might be acting there. So whenever you look at papers talking about minimal change or FSGS, you always see these pictures where it's like a lot of question marks and like maybe this, maybe something's acting on the actin, or maybe something's acting on nephrin, or perhaps it's a soluble factor. Because it really seems like there's some soluble factor, right? Like we transplant FSGS patients and then it immediately recurs, but like we can't figure out what the soluble factor is. So, but that's sort of where we were basically until 2021, when a group out of Harvard, a pathology group out of Harvard, looked at anti-nephrin antibodies. And the reason they looked at anti-nephrin antibodies were, one, because they're, from 2006 onwards, there is actually pretty good data, or some data in pediatric patients that rituximab is effective for minimal change. So they were thinking perhaps there's some B-cell mediated. We've always thought this is T-cell, maybe it's B-cell. And then also because, you know, whenever we look at these biopsies of minimal change, the IF, there's not any immune complexes, but there is like a little bit of IgG kind of in the background, and they always thought that this was just like inconsequential. But then they're like, wait, what actually is that IgG? What is it doing there? And so the theory was that anti-nephrin antibodies or this IgG might lead to redistribution of nephrin away from the slit diaphragm, leading to separations of the intercellular junction between adjacent podocytes, causing proteinuria. So basically this group at Harvard took sera and biopsy tissue from patients with active and in remission minimal change disease, and they saw the presence of anti-nephrin antibodies in 29% of patients with active minimal change, but it wasn't present in the sera once they were in complete remission or partial remission. And the serum levels matched the presence of IgG on the biopsy. So you can see the IgG and the nephrin sort of co-localizing on these biopsies. So then this was kind of further evaluated in a New England Journal paper that came out in 2024 by Hingle et al. And looked at the anti-nephrin antibodies in idiopathic nephrotic syndrome, meaning, you know, nephrotic syndrome, NOS, haven't been biopsied, minimal change, primary FSGS. And this is kind of what they found. So anti-nephrin antibodies were measurable in the serum of these patients with minimal change disease, with nephrotic syndrome, but not as much in these, you know, lupus, ANCA, IgA. There was one in membranous, but they think that maybe there was like a membranous minimal change overlap, which can happen. And then the more like, you know, nephrotic you are. So if it's minimal change, they're nephrotic, they have not been on immunosuppression, the higher these anti-nephrin antibodies. And compared to the controls where there's just essentially none. So pretty kind of interesting, and definitely like a step kind of in the right direction of finding this potential circulating factor. This was just in 2 patients where they measured the presence of anti-nephrin antibodies, and you can see how it like drops when they go into remission, and then when they relapse, it increases, and then they get rituximab, and then it's like gone, essentially. So I think it was very cool. So the takeaway is that, you know, it's been unclear what the circulating factor is. There's a lot of theories, but, you know, there's a decent amount of patients in these studies, you know, 60 to 70% of minimal change patients who had this anti-nephrin antibody. And it gives clinical significance to that background IgG that's been seen in IF, suggests a new mechanism, and also suggests a mechanistic rationale for why rituximab has been observed to be efficacious.
This is kind of topic still, right?
Totally.
Yeah.
Yeah, but I think there's more and more.
I'm excited about
support
it, but
for
then
it.
like if you look at the New England Journal of Medicine, the editor sent like a paper that basically destroyed the Harvard group, which is kind of harsh. But I would love to have something that we could measure and not have to biopsy like
Yeah.
into our.
It was definitely very controversial when it came out in 2021. And so when I was updating this talk, I was surprised to see that there's a lot more on it actually now, and a lot more support for
That's
anti-nephrin.
great, yeah.
Okay, so kind of switching gears a little bit into like your clinical course of minimal change and treatment options. So obviously, you know, our diagnosis is by biopsy. We have the initial treatment often is going to be supportive measures with, you know, best measures, ACE and ARBs. Maybe if they're not like floridly nephrotic, good low salt diet, fluid restriction. And then, you know, of the patients with minimal change, actually, a third of them will spontaneously resolve in about 2 years. But treatment is typically indicated once they're diagnosed because usually they're pretty nephrotic. So on top of supportive measures, you're going to treat them with steroids. And then oftentimes steroids are very effective, we know, with minimal change. So they'll go into remission, and that can be defined as complete, which is less than 300 milligrams per day of proteinuria, or partial, which is going to be closer to 300 to 3.4 grams per day. and then no remission or you're steroid resistant, meaning that they don't respond at all. So typically it's going to be 3 to 4 months of steroids for remission. In these patients, remission rates is good, so 80 to 90%, but 10 to 30% of these patients are going to be steroid resistant. And then in terms of relapses, so 2/3 will relapse on steroids alone, 25% will frequently relapse, and then 30% will become steroid dependent. Okay, so when we talk about treatment options, obviously steroids are kind of our main go-to for minimal change because they do respond so well. And just know that a lot of the studies for steroids on minimal change in adults come from pediatric studies. But in general, PO steroids have a better immediate remission than no treatment or placebo. And long-term remission rates were the same between groups. And then retrospectively, over 80% of patients were in remission by 16 weeks of steroids. And you can do that either by daily dosing or every other day dosing. So historical treatments that are non-steroidal, and these are for patients who maybe either have contraindications to steroids or who are frequently relapsing or who are steroid dependent, are Cytoxan, the CNIs, mycophenolate, and then rituximab. And so the key takeaway for all of this is that these are not great. There's not a lot of great studies. So there's some randomized controlled trials for Cytoxan, 2 small ones for the CNI, or 3 small ones for the CNIs, 1 pediatric one for mycophenolate, and then rituximab was just sort of observational studies. And there were randomized controlled trials in peds, but so that's kind of where we were at. When the KDIGO 2012 guidelines came out. And so for a long time, basically your treatment was steroids. And then if they were dependent on steroids, the first line was going to be oral Cytoxan because that's what had the most number of randomized controlled trials. And then if that was not a good option, or maybe they were a childbearing age, then you could do CNIs. But there's pretty high relapse rates in these. So like CNI relapse rates are like 60 to 70% versus or 40 to 50%. Less so with Cytoxan, but that's also like a harder, that's not a great one. So that's kind of where we were as of 2012. So steroids were effective in initial treatment, but there were high rates of relapse. And that led to an increased exposure to steroids and increased complications related to steroids. You could use, if they weren't a good option, you could use Cytoxan or CNIs, rarely MMF, but generally this is all limited by the number of studies. So then we go into some newer studies that came out. So this is looking kind of like 2018 onwards. And this is what influenced the 2021 KDIGO guideline changes. So the first one is the MSN study. So this is looking at low-dose steroids plus mycophenolate in patients with minimal change. So this was a multi-center randomized controlled trial across France, looking at low-dose steroids and Myfortic versus standard steroids, looking for complete remission after 4 weeks of treatment. Primary endpoint was the percent of patients reaching complete remission at 4 weeks, and then secondary endpoints were complete remission at 8, 24, and 52 weeks. So this is the initial relapse-free probability range, and so this is the test group for the Myfortic group versus the control group, and so basically they were on treatment for 24 weeks, and then they were followed for 52 weeks. And the outcome was that there really was no difference between the 2 groups in the rates of remission at 4, 8, and 24 weeks. And there was really no significant difference in relapse rates, no significant difference in adverse outcomes. Problems being, criticisms with this trial was that it was open label and there was some attrition bias. So that was Myfortic. Then there's MinTAC. And so this was looking at CNI monotherapy to steroids for the initial treatment of minimal change. So this was, again, multi-center randomized controlled trial in the UK. This was actually a non-inferiority study. And this looked at the percent of patients that were in complete remission at 8 weeks with tacrolimus. And then secondary outcomes were complete remission at 16 and 26 weeks, the rates of relapse, changes in creatinine, and then adverse outcomes. So they actually just had 50 patients that were adults. They had a new diagnosis of minimal change by biopsy, and they had not gotten any immunosuppression in the past 18 months. So we looked at tacrolimus versus steroids, which is, basically 60 mg per day of prednisolone, and then gradually tapered off over 6 weeks, whereas TAC was maintained for 12 weeks after complete remission and then gradually reduced. And so the results, unfortunately, this didn't meet the definition of non-inferiority, but even so, there was no significant difference in the primary and secondary outcomes, which, doesn't mean that you can't use CNIs, that potentially there's an option for use of CNIs in patients with contraindication to steroids, but it's not really any better than steroids. And so, again, it's open label, it was pretty small, it was just 50 patients. And then TAC was continued much longer than prednisone, so another thing to kind of keep in consideration. And then also in 2018, there was a very small 6-patient retrospective study of 6 patients. And this was basically looking at use for rituximab in treatment naive patients. So people, I think this was really the first time it had been looked at for people as induction. We're using rituximab first line here. And this was they chose these patients because they had contraindications to steroids. And there's not a lot, this is a very short paper, not a lot of information, but essentially their proteinuria just plummeted. I mean, they all did actually kind of amazing. And then they stayed amazing for 9 months. So all of them, I think, except one, got to complete remission.
Sorry, were these people on steroids as well?
It was just rituximab
Just,
because they had contraindications to steroids.
oh, I see.
Mhm. So this was the first report of adult minimal change that was treated with rituximab as first-line therapy without steroids or other immunosuppression. All patients had remission, one was partial. So, there is some degree of spontaneous remission that occurs with minimal change. Maybe that's what we're seeing, but hard to say. Again, very small retrospective European case studies. But so these were the studies that then kind of informed the KDIGO 2021 guidelines. So you have minimal change as initial therapy. If they don't have contraindications to steroids, KDIGO is still recommending steroids. If they do have contraindications, Cytoxan is still listed as number 1, probably because that's the one that has the most number of RCTs behind it. CNIs, mycophenolate, perhaps you can use, but as we saw in those other studies, there really wasn't. They weren't superior to steroids alone, but perhaps that could help you with steroid sparing. And then now we're starting to include rituximab into the guidelines, and they're saying, oh, maybe rituximab. And then for people who are frequent relapsers or steroid dependent, and they've already gotten Cytoxan or they want to avoid Cytoxan, then they recommend you can use rituximab, CNIs, MMF. So since this came out, there have been more studies in rituximab, and there's a lot of people that are very excited about rituximab, I would say. So I will say first off that there is a randomized controlled trial that's going on right now in France. It hasn't finalized yet. And this is looking at people getting, with their initial flare of minimal change, haven't been treated before, getting Ritux. And they're on steroids, but it's a very shortened course of steroids versus just steroids alone. I checked clinical trials and it's still pending right now, but also in 2024, there's a decent sized Chinese retrospective cohort study of people who are steroid resistant or steroid dependent, both minimal change and FSGS. And 81 of them got Ritux with an average dose of about 1,400. And then 70% of them were able to stop steroids within the first 3 months of Ritux. actually don't have more on this study because when I tried to open it on PubMed, it's like a physical paper and I couldn't find it. So this is the abstract. And then there was an Israeli study recently in 2025. It's a little bit smaller, but again, 21 adults, some with FSGS, some with minimal change, who are steroid dependent or frequent relapsing. They got the 1 gram times 2 with an additional 1 gram at 6 months if they needed it. It was kind of per the doctor's discretion, or additional if they had relapses later on. They were followed for 39 months. 66% of them maintained a prolonged remission. And the first time to relapse was significantly prolonged compared to just steroids, and the number of overall relapses was reduced. This is their like funny little graphic. So before rituximab, the number of relapses, this is after, so it drops to like 0 to 1 compared to 2 to 4.5 number of relapses. And then this is like the time to relapse in days. So before rituximab, after rituximab.
Did they comment on what their first line treatment would be when they did relapse? Like when they relapse?
They got retux.
Okay.
Yep, they would give like additional 1 gram or it didn't really, I didn't see actually like if they would just re-induce them with 2 grams if they were like far enough out. But for sure, if they were like 6 months and maybe still in partial remission, they would give them another gram. Yeah. So just some future steps. I just thought this was interesting. I found this in KI, but the same group that studied the anti-nephrin antibodies out of Harvard started looking at these in pre-transplant patients because we know that there are some patients with a primary FSGS who will recur. And again, very small study, so just 39 allograft recipients, but what they found was that the positive pre-transplant circulating anti-nephrin antibody was associated with recurrent diffuse podocytopathy. And the sensitivity and specificity for recurrent diffuse podocytopathy was 38% and 100% specificity, which is crazy. And then they did see like punctate IgG co-localizing with nephrin in patients with recurrent disease. So kind of an interesting take for, you know, maybe looking into the future for these patients. But that's kind of where we're at with minimal change in FSGS. But come a long way actually, because it seemed like things were sort of stuck for a while.
So how, I mean, obviously it's patient specific, but how do you usually treat? Do you usually use steroids if they have no other contraindications, or do you sometimes do retux with steroids, or I
Yeah,
don't know. Yeah, what do you do?
I mean, these days I would do steroids and retux,
Sorry.
like steroids and retux
Yeah.
to help
Yeah.
like cut the flare. And I mean, Gina and I have a patient who we just gave retux to. And you know, the idea being like also, how can we like prevent relapses? I mean, Gina's patient is like a frequent relapser and has had multiple courses of steroids. He's not very trustworthy either.
Yeah.
It's not like
Question mark to all of them.
question mark to like how well he's actually taking his meds. But another reason why retux might actually be a good option for him because it's one less thing for him to think about. But so he got his first dose of retux last week and he's on like a taper of prednisone too.
How would you typically, like if you're doing steroids plus retux, like obviously he's kind of atypical in how we went about it, but like
Yeah.
how would you typically give, like how long would you typically give 6 to 8 of pred before you start weaning?
Oh, that's a good question. I think, you know, I don't think I would do like this, if you were giving retux too, I wouldn't do like the standard course. I think you could do a shortened course. I mean, he is a little bit different. But I think one of these studies had,
2025. Trying to see what
Yeah.
they did with prednisone.
they did, I think they did this one did a shortened, like, they basically, oh no, this one's really short. I have to look it up.
The 2025 one says all patients received 1 milligram per kilogram, max dose is 60 mg daily, and then once achieved remission, they withdraw prednisone according to regimen. which is like,
Complete or
yeah,
partial?
exactly.
Yeah.
Some
Um,
people may take a long time to achieve. You're keeping them on steroids for,
Well, a lot of these people too, I mean, like classic minimal change, sometimes they respond fairly quickly. And I think the idea of Vertex is more that I mean, Vertex itself, like we know, really doesn't work for the first 3 months, right? So like the steroids help control the nephrotic syndrome. But then the Vertex is like gonna really help reduce the relapses. And so like I don't think that there's like a designated description of how to do your steroids, because every study seems to be doing them a little bit differently. Like the one in France, I think it's a very quick taper. But and I think there's also some like clinical caveats too, right? Like, there's a lot of fear about giving rituximab to somebody who's really hypoglobulinemic. And so if they're really nephrotic, it might behoove you to get them less nephrotic before giving them rituximab to lower their infection risk.
on their regimen, it says 16 weeks from day 0, they keep, and then they would reduce it till after 16 weeks, and then that means all remissions. They have them on 60 for 16 weeks. Which
That's,
is,
the thing to remember is that it can take up to like 16 weeks for remission.
You ever
It's a
use
lot of
oral
stuff.
corticosteroids?
Just get some of that.
Or CNIs?
Just never have.
Yeah.
But honestly, all my minimal change patients are genus patients.
We do have the one, our IGM patient who's not really minimal change, but he's nephrotic.
And then do you have the lupus photocytopathy lady at Denver Health?
maybe. I also had a minimal change patient there as well.
I have
Thanks. Okay. Oh, maybe two.
Have you
I think
seen
she's on steroids.
the
Yeah.
letter to the editor from these people too?
Oh, yeah.
It's like,
Very pissed.
they just start with like, these people claim to have shown auto antibodies, however, at no point do they directly show any anti-nephrin antibodies in patients. And then they're saying that they're like manipulating the protein G beads to show what they want them to show. Basically, like it's pretty scathing, it's like,
2 paragraphs.
and it's like two French.
But it was repeated, right? You said it was in 2021 and 2020.
This is from the
This is in
2024.
response to the 2024 one.
They still,
But they repeated it. It was done in 2021, they showed it, and then in 2024, a different group.
I think it's the same group, and then this is a response to the 2024.
It's definitely not the same group.
Oh, no, it's not.
The 2024, the New England Journal was a different group.
Oh, okay. Yeah,
and
this is
then
the
2021, was out of Harvard.
Campbell et al. is the New England Journal of Medicine group.
Yeah.
But, and then these two French research nephrologists are the ones that wrote this.
I mean, it definitely is, there is like.
It's like crazy.
Yeah.
I mean, I think in what Judy will say, because obviously Judy's like the photocyte queen, is that these are very like, it's heterogeneous. You're not really sure if, not every FSGS recurs after transplant, right? So there must be something else or some other thing that is possibly being affected. And clearly the anti-nephrin antibodies aren't seen in every person with minimal change. So I think it's still like a little unclear if this is like for sure whereas with membranous, it's like, okay, we've got our antibodies.
Yeah, I was gonna say,
Yeah.
it feels like PLA2R, where
It would be
they're like,
great.
it's in like,
Yeah.
X amount of patients, what about the other amounts, and then they're
Right.
finding out other antibodies.
Right, but it was interesting, because when I was looking at the studies, when I was in fellowship, there was a lot of like, I don't think so about anti-nephrin, and then really since then, it's actually seems like it's got a lot of speed, and a lot of people are kind of veering towards using rituximab more for these patients. Something B cell mediated, and there is actually obinutuzumab is being looked at also, so
For FSGS or?
for minimal change.
No.
Yeah. Interesting. Great. Well, thanks, guys.
Cool, thank you.
Yeah.